Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, I am Kelly Shanahan, and I'm here to talk to you about the patient experience, insights into the patient journey living with ER-positive metastatic breast cancer. I've been living with metastatic breast cancer for almost 12 years, but in my pre-MBC life, I was an obstetrician gynecologist, so I know life on both sides of the stethoscope. Here's an overview of what we're going to talk about today. You clinicians are experts in treating cancer, but we patients are experts in living with cancer, and we should be considered the central point of the care team. And the care team is so much more than doctor and patient. The care team is also the clinical pharmacist who's very often underutilized in helping educate us patients about our medications. It's the nurses, especially the infusion room nurses, who we spend way more time with than we do with you, and who we often are a bit more forthcoming about with what we're experiencing with our treatment. It's the social worker who can address barriers to care. And it's also those people who accompany us to our visits, our family, our friends, our care partners. It's vital that we communicate clearly with one another. For you, that means explaining our disease, including subtype and any mutations that may be present, our treatment options, the side effect of those options, in plain language. This is not the time to use those multi-syllable words that you perfected in medical school. For patients, it means letting our care team know what is important to us, being empowered to ask for clarification if we don't understand something, and letting our team know how we're doing with the treatment regimen. And I mean really letting our team know what's going on, not just what we think they want to hear, not minimizing side effects because we don't want to stop an otherwise promising treatment. And back to you clinicians, take the time to ask patients to tell you what they thought you said, to make sure that they and their care partners understand and have resources available to reinforce the basics. What is metastatic breast cancer? What are the subtypes? What is a clinical trial, etc.? Know the major patient-facing organizations that can help educate and empower your patients. In order to engage in shared decision-making, you have to know your patient. You need to ask what she or he wants to get out of treatment. Is it to live as long as possible? Is there a milestone they want to achieve, like a child's wedding or the birth of a first grandchild? Do they want to feel as well and as normal as possible, even if that might mean choosing a shorter overall survival in favor of a better quality of life? Then, when you are discussing treatment options, give the salient facts, again using plain language, like the typical person on this medication will get 20 months before their disease starts to grow again. Or 50% of people on this drug are still alive and still on it 5 years down the road. Give all the options, including clinical trials, to all the people. Do not assume that a particular patient wouldn't participate in a clinical trial because of their background. Do not assume that a particular patient may not choose a particular therapy because of side effects. Everybody is different, and you need to individualize the care. And please, please do not use terms like side effects are tolerable unless you've been on the drug. Just tell your patients what the side effects are, roughly what percent of people experience what side effect, and what remedies there are to deal with those side effects, including prophylactic medications and the side effects of those prophylactic medications. This is another place where pharmacists and nurses, and especially palliative care, can be extraordinarily helpful. So include these other disciplines in the care team. And right off the bat, tell the patient that if they are experiencing side effects, that dose reductions can allow them to stay on the medications without significantly compromising efficacy. Dose reductions are always an option that is all too frequently not mentioned. And you merely mentioning that there are resources to learn about metastatic breast cancer empowers your patients to seek information and lets them know that you value an educated patient. Knowledge is power. Knowledge is a tool against fear. Knowledge provides hope. If you're a general community oncologist treating every different type of cancer, please encourage your patients to get a second opinion from a breast oncologist, one who treats a lot of people with MBC. I know when I was practicing and my patients wanted a second opinion, I felt really smart if the second opinion doctor agreed with what I had recommended. And if they didn't, I learned something new. A prepared, informed patient will make your life easier in the long run. Thank you for listening. Thank you for participating in this activity. And please continue on to the next segment where you'll hear Dr. Virginia Kaklamani and Dr. Sarah Talani discuss recent clinical data related to oral SERD-based regimens. Thank you.
Welcome to our Medscape Oncology program on the evolution of care in estrogen receptor positive, HER2-negative metastatic breast cancer. My name is Sarah Talini. I'm a breast medical oncologist at Dana-Farber Cancer Institute, and I'm joined by my colleague and friend, Dr. Virginia Kaklamani, who is professor of medicine at the University of Texas Health Science Center, San Antonio, and leader of their breast cancer program. Thank you so much for joining us today, Virginia.
No, thanks, Sarah. This is going to be a fun discussion.
Yeah, well, we've seen such an evolution in care for our patients with metastatic hormone receptor positive breast cancer. And I think one particularly exciting area has been the introduction of oral SERDs. And so I thought maybe, Virginia, you could just kind of start off and tell us a little bit about these drugs and why these have been so exciting for us to have in clinic compared to what we've had to date.
Yeah, so we've had fulvestrant for over 20 years now, treating patients with metastatic HR-positive breast cancer, and we know the fulvestrant outperforms aromatase inhibitors when given at a higher dose. But we can't give an even higher dose because of the IM injection and how much we can inject. And so this has always been the limitation of fulvestrant. And so these novel oral SERDs, because they're oral, that we can push the dose up. And the reason we care about this is the fact that these tumors, when they evolve and become endocrine resistant, many of them develop ESR1 mutations. And these ESR1 mutations need more drug to be able to really be suppressed. And so this is where these oral SERDs have emerged. Elacestrant, which has been approved now for a couple of years, imlunestrant, very recently also approved, and many more coming. So this is an evolving but really exciting field as well. So Sarah, we've seen the data with Emerald. We've seen the data with Ember 3. What is your impression when we look at all of these agents and the data that's being generated? How do you evaluate these oral SERDs?
Yeah, no, the very first trial, as you point out, that we saw with an oral SERD that led to approval was the Emerald study, which really compared oral elacestrant to physician's choice endocrine treatment. And it was in a population of patients who had all seen a prior CDK4/6 inhibitor. They also could have had up to a line of chemotherapy. And what we saw was a significant improvement in progression-free survival, going from about 1.9 to 3.8 months. But I will say, I think we were a little disappointed by the median number. Getting it to about 4 months, is good, but certainly not a home run. But I think what we learned when looking at that trial were that there did seem to be some patients who have really prolonged benefit to these drugs. And it seems in particular to be the patients who had prolonged benefit to first line therapy with endocrine treatment and a CDK4/6 inhibitor. So if you're on, for example, your upfront endocrine treatment and CDK4/6 inhibitor for more than 12 months, then in essence, we were getting a PFS of around 8 months in that post progression setting. And that was really nice to see, especially just with hormonal therapy alone. And so I think, it has been an option for patients who have progressed on a CDK4/6 inhibitor where we think they have some endocrine sensitivity left in them and we think we're going to get benefit. So that has been nice. But as you pointed out, we just very recently saw a new approval for another oral SERD, imlunestrant. The trial design for this study was a bit more complicated. So I thought I'd ask you what you thought of EMBER-3 and the benefit that we saw with imlunestrant in that trial.
Yeah, so the trial was more complicated, 3 different arms, and the third one, which was the combination of imlunestrant and abemaciclib, was added later on. But the main trial that compared imlunestrant to fulvestrant was a nice design. The majority, around 60% of patients, had previously received the CDK4/6 inhibitor, but not all, like Emerald. So the patient population was definitely different, a little less heavily pretreated. But in that trial, as we saw with Emerald, imlunestrant outperformed fulvestrant in the patients that had tumors that harbored these ESR1 mutations. In the non-mutated tumors, it seemed that there was no improvement with imlunestrant compared to fulvestrant. And that, to me, that also shows that we have good endocrine therapies. Just with these ESR1 mutated tumors, we need stronger ones to be able to get that benefit. Now, the combination arm did much better, and the combination was compared to imlunestrant, which was a little interesting as far as the design. But the combination was not approved; it was not really submitted to the FDA for approval, and the combination seemed to outperform imlunestrant in both the ESR1 mutated tumors and the wild type, which again was a little interesting to me as well. Um, so based on Ember 3, based on Emerald, I think the standard of care in patients that we want to give endocrine therapy to that have ESR1 mutated tumors should be an oral SERD. I don't know whether you do that as well in clinic.
Yeah, so I will say wanted to be able to give patients oral SERDs. I haven't yet been able to give imlunestrant with just the very recent approval, but with elacestrant, certainly I've been trying to be selective though about the patients that I want to give elacestrant to, really based on what we saw in Emerald with those patients who had prolonged benefit on upfront CDK4/6 inhibition, being those patients that I would think about elacestrant for. And so really, again, a really nice option to have a drug that is so well tolerated as monotherapy for that select group of patients. We've also seen other drugs that are coming along. We saw recently just at ASCO the oral Protac vepdegestrant being presented when it was compared to endocrine monotherapy and also saw benefit. But yet again, I was a little bit surprised, I'll be honest, because I had been hoping, since vepdegestrant had a little bit of a different mechanism of action, um, that we would potentially see benefit that was not just isolated to patients with ESR1 mutations. But yet in this trial, we still saw that vepdegestrant was better than endocrine monotherapy only in patients who had an ESR1 mutation. That if you looked at those patients that were ESR1 wild type, in essence, it was performing the same. And so we're hoping we'll see approval also for vepdegestrant in the near future as another option for patients with ESR1 mutations. But we still haven't seen a monotherapy SERD have activity in the wild type population. And I'll say for me, this is a bit disappointing. Fulvestrant, as you pointed out, requires intramuscular injections. And I wish there was a way to get approval for these drugs in patients, even though they are ESR1 wild type, because they seem to work just as well. They're not worse. And I would argue they're better tolerated than having to get a shot. So to me, that's a bit disappointing, but hopefully we will see other ways to get SERDs in the wild type population. I think one way could be combination therapy. So, Virginia, you brought this up with the complex EMBER-3 design. So I guess I'll ask you the hard question, which is when you saw the data for imlunestrant plus abemaciclib, where it did seem, I mean, I thought it was a very impressive PFS to get to 9 months, even in the subset that was post CDK, you're seeing this robust PFS. And so, do you think that this is a combination that should lead to an approval that we should be able to utilize? I think the challenge that you brought up was the design of the trial where it was compared to imlunestrant monotherapy. Um, I'm curious to get your thoughts on that.
Yeah, and this is not the only combination trial. We also have the Electra results with elacestrant plus abemaciclib. Again, we're getting to that 8, 9 month median PFS, which I think is impressive, especially in this more heavily pretreated patient population. I'd like to be able to have the options that to either use combination or use monotherapy. Obviously, the combinations are going to give us more toxicity compared to the monotherapy, but some of these patients may need a little more. And when you look at the trials, both EMBER-3, Electra, and you compare them to Emerald, this rapid drop that we see in these patients where there's progression within the first scan is less of a drop in the combination treatments. And so if we're not sure who is the patient that will have that endocrine resistant phenotype, which many times we're not sure, then it's nice to have the option of giving the combination therapy. Thankfully, we have other trials such as the Elevate trial that is going to look at every combination there is with elacestrant, and so we'll have all of the different CDKs. We'll have capivasertib, alpelisib, everolimus, the Avera trial, and then also looking at first line trials with CDKs and oral SERDs that I think will probably change the field.
You mentioned also the Avera study, which looked at the combination of giredestrant, so another oral SERD, with everolimus, and compared it to endocrine physician's choice plus everolimus. And we know that that is a positive study suggesting that everolimus giredestrant combination um, is an active one and better than standard endocrine therapy everolimus. And so, if that comes to yield an approval, I'm curious, Virginia, how would you think about it? Let's pretend at some point in time, imlunestrant and abemaciclib does get an approval, and let's pretend giredestrant everolimus ends up getting an approval. We obviously don't yet know within uh, the Avera study if that benefit is restricted to those patients with an ESR1 mutation or not. We'll have to see those data. But how would you figure out who the best combination partner is? I think this is a struggle that I have, is who gets continuation of CDK beyond progression? Would you use an mTOR inhibitor in, and how do you think about that?
Well, up until now, I haven't really used CDK after CDK. I was a little disappointed with the post Monarch data. We're talking about a 0.7 month improvement in median PFS. And so I hadn't done that. But as you mentioned, the EMBER-3 data with a combination was much more impressive. And so, yes, I'm going to have to wait and see what the giredestrant everolimus data is, because my go-to second line for patients that don't have any mutations in their tumors is to give everolimus. And so I'd be very happy to just give giredestrant and everolimus to these patients. I think we're going to have a lot of options. We also had results from the Victoria 1 trial just to make things even more complicated. So now we have another new kid on the block. And I think those options are not going to make it easier for us. I think they're going to make it much, much harder for us unless we start thinking, well, maybe I should do the Serena 6 approach, and maybe start looking at ESR1 mutations in real time and switching to the oral SERD in that first line setting, which might dictate what we do in the future. But let's look at what we would do now with the approvals that we have. We have elacestrant, we have imlunestrant, and we have PI3 kinase AKT inhibitors. How are you treating your patients starting with first line therapy?
Yeah, I mean, for an endocrine sensitive patient, so someone who either had de novo disease or had, more than a year or two of a disease-free interval from recurrence on adjuvant endocrine therapy, then I'm usually giving an aromatase inhibitor and a CDK4/6 inhibitor. Obviously now it is a little bit more complicated because if someone had early relapse or had endocrine resistant disease in that upfront setting, we obviously need to know PI3 kinase mutation status to make that first line decision to know if they would be a candidate to get fulvestrant and abelacib palbociclib, or whether or not you would just give them fulvestrant with a CDK4/6 inhibitor in that upfront setting. So usually it's some endocrine CDK4/6 and then maybe a PI3K with it if they're in a endocrine resistant group that has a mutation. So I think that is currently standard, but I think you mentioned Serena 6. We'll have to see if that yields an approval and if we will start potentially monitoring our AI CDK patients for emergence of ESR1. But there are also trials ongoing looking to completely replace the AI with an oral SERD in the upfront setting that haven't reported yet. I'm curious, do you think that they'll be positive? Because obviously, in that upfront endocrine sensitive population, rates of ESR1 mutations are going to be exceptionally low. And so, do you think they'll work to really prolong PFS?
I would have said no pre Ember 3. And with Ember 3 and the fact that we saw an improvement in both mutated subsets and non-mutated subsets, I've been a little more open to the idea that we may actually see differences. And obviously, we have the adjuvant trials going on too that might shed some light. So, yeah, I mean, if you see the Serena 4s becoming positive trials, then we'll be using these oral SERDs in the first line, not waiting potentially until disease progression or ctDNA emergence of an ESR1 mutation, which will really change things. And then obviously we have the PI3 kinase inhibitors. And one of the questions always is, what do you do with the co-mutated patient population? Do you give a PI3 kinase inhibitor or do you give an oral SERD? And neither of us really know the answer.
I wish I knew the answer to that question. I think it is hard, and we do see these patients. Probably somewhere around 15% of our patients will have both ESR1 and PI3K mutation. And if someone's progressed on a CDK4/6 inhibitor, I think you're right. The question is for now, are you going to give them elacestrant or imlunestrant monotherapy, or are you going to give them, for example, fulvestrant and capivasertib? And we only have some subset data, both from Ember 3 and from Emerald, where it does look like the patients who get PI3 kinase mutations do well with monotherapy SERD. But again, I think they're pretty pre-selected patients who tend to be endocrine sensitive. And so that's where I think this becomes a bit of a struggle, is that it might be right for some patients, but not for all. And I think we need a little bit more information there. One thing we didn't really touch upon, Virginia, were toxicities from these oral SERDs. And I'm curious what your experience has been to date with these drugs and if you've had any challenges with tolerability.
Yeah, I've given quite a bit of elacestrant both on and off trial, and I've found it to be pretty well tolerated. There's some GI toxicity, which we see with all of these oral SERDs, but well tolerated regardless of that. The other SERDs may have a little difference in the toxicity profile, some bradycardia, so forth. But overall, very mild, grade 1 to 2, which I think is really important for these patients that we care about their efficacy and we care about improving overall survival, but we also care about maintaining quality of life.
I think that's very well said. I think the big take home for me with these agents is that they are very well tolerated and offers a superb alternative to fulvestrant, which we've had to date as our IM SERD. And now to have oral SERDs is wonderful for our patients. And hopefully, as we've alluded to, we'll see combination strategies move to approval, hopefully in the near future, which would be tremendous for our patients. So thank you, Virginia. I think this was a wonderful conversation. I certainly always learn a lot from discussing things with you. And thank you to all of you who are listening and for participating in this activity. Please to continue on to the next segment where you'll hear Sarah Donahue and Abigail Shockley discuss nursing and pharmacist management approaches related to oral SERD based regimens. Thanks so much.
Thank you.
Hi, everyone. Thank you so much for joining this Medscape program titled Refining Patient Communication and Monitoring Using an Interprofessional Approach. My name is Abigail Shockley, and I'm a clinical pharmacy specialist in breast medical oncology at MD Anderson Cancer Center in Houston, Texas. And joining me today is Sarah Donahue.
I'm Sarah Donahue. I'm a nurse practitioner in breast medical oncology at the University of California in San Francisco.
Thank you so much, Sarah. Well, let's start off. We're introducing oral SERD therapy to patients and estrogen receptor positive, HER2 negative metastatic breast cancer. Communication really sets the tone. I recently worked with a patient transitioning from fulvestrant to oral elacestrant, and now we even have the option of imlunestrant, which is very exciting. She was really thrilled about skipping clinic visits, but really anxious about managing her medications alone. How do you usually approach that first conversation?
Well, this is a familiar scenario. I start by validating their concerns and help them build a routine around taking their medications. Sometimes it's creating reminders, like a little alarm in their phone to say, take your meds. Um, with oral SERDs in particular, taking meds with or without food. So aligning it with something else that they're doing can be really, really helpful. In my practice, when patients are starting a new therapy, we set up weekly check-in call with one of our nurse. What do you do in your practice with those kinds of strategies for helping patients remember to take their meds?
Yes, Sarah, those are great strategies. I often recommend very similar strategies. I often recommend seeking doses with daily habits. And I also reassure them that missing a dose occasionally isn't catastrophic, but to let us know if maybe it happens more than once a week. And it's really crucial that our messaging is consistent across the team. I remember this particular case where our dietitian flagged a patient who was losing weight really rapidly. It turns out that she was actually just experiencing nausea from her new medication, but she hadn't told me. Once I was looped in, we adjusted her dose as well as added on an oral anti nausea medicine. And that collaboration between dietitian and our pharmacy specialist group really helped turn things around for the patient.
That's a great example of something like that potentially falling through the cracks, but then having a whole team of people to help out. I had a patient, a similar type of situation where there was a side effect that we didn't predict would happen. She had a rise in her liver enzymes. And we thought that maybe that her cancer was getting worse. She was like having growing tumors in her liver. So uh, we really were worried about that, but then we reviewed her meds with her one by one, and we found that she was taking a turmeric supplement. So we told her to stop the turmeric supplement, and we followed her labs up like a week later, and her labs had normalized. And so it's just a reminder that patients often don't realize that supplements can interfere with their treatment. In my practice, when patients are starting treatment, our pharmacists and nurses discuss supplements with them. We actually don't have great studies to see what the interactions are with our particular medications that we're given. So, like elacestrant, sometimes you can have rises in their LFTs that could be from the drug. So, it's really important that we review this information with the patient. And if they feel like they really want to take the supplement, we just have our triage team tell them that, talk with your provider when you see them and they can figure out if it's safe. Um, but general overall rule is to stop the multitude of supplements. What do you do in your practice?
Sometimes I use the brown bag approach. And what that essentially means is I ask our patients to bring all their medications, supplements, and vitamins to every visit. Once I had a patient bring in a whole tote bag full of supplements and medications, and it was very significant because we discovered that the patient was actually doubling up on calcium. It can definitely be chaotic, but it can be effective for certain patients. And what are your thoughts on this? Do you think that this is something that we should standardize in our practice?
In my personal practice, if a patient were to bring in all their pills every single time, that would be a little overwhelming for my 30-minute visit, but it's probably the gold standard. It's probably the only way to really know what patients are taking.
Agree. Let's discuss how we can educate patients on potential side effects from these medications. What do you in particular tell your patients to look out for?
For the oral SERDs, I tell them about nausea. That's a common side effect. Diarrhea with imlunestrant, actually, as well. So nausea with the elacestrant. So one thing that I found is if I have them take it with a meal, it really helps. I had one patient that was taking it 30 minutes after she ate, and she was still having nausea. So she moved it up to like literally while she was eating, like take a bite of food, take your pill. And that really, really helped to minimize your nausea. I've had another patient where we switched it to bedtime so that she was nauseous when she was sleeping and she just slept right through it. What other side effects do you educate patients on for these medications?
Well, you definitely mentioned my top two, diarrhea and nausea with these oral SERDs. But as you know, joint pain is another common side effect that we need to educate our patients on prior to starting these oral SERD therapies. But many of them are pretty familiar with this particular side effect because they have taken an aromatase inhibitor and maybe have experienced joint pain from that. I tell them that generally the joint pain with these oral SERDs is much less common, but still can occur. I had a patient who actually developed joint pain and assumed it was just aging, but after reviewing her timeline, we linked it to her oral SERD and actually switched her to an evening dose, just like you did once for the nausea. And then we also added acetaminophen, which really helped. And with that, how do you help patients distinguish between treatment related side effects and then unrelated symptoms?
I'll ask them when their symptoms started. Um, Sometimes that can really help. Like if they start a medication and a few days later they start to feel a symptom, then it's probably from the medication. You can rule out other things, but it's probably from that. I also ask them if they already have a symptom that predates starting the medication. I always ask, did it get worse? So really just making sure to understand what's happening and when and what they're doing about it. And then I do find that patients will sort of blame their medication for a lot of their symptoms. So I think really, helping them to sort of parse that out is really helpful.
Yeah, I definitely agree. It's very important to do a thorough interview when it comes to symptoms and determining what really causes what. That being said, what's kind of your follow up cadence for new starts?
So I have them do labs with like a CBC differential and LFTs or a comprehensive metabolic panel is what we call it where I am. So at baseline at 4 weeks, then monthly. I generally see them monthly for the first 3 months to ask about symptoms. Um, do you use any tools to track side effects with patients when you're following them?
Yeah, so when I educate patients, I often recommend a symptom tracker app if they're savvy with their phones, or pen and paper and using a notepad or even the Notes app in their phone, just to help flag trends. And I had one patient actually log their daily fatigue scores, which really helped us identify a pattern linked to her specific dosing time, where we were able to shift her medicine and saw an improvement. It's really simple, but it can be a very powerful tool when patients are able to track their symptoms. How do you, in particular, approach the discussion between intramuscular fulvestrant or an oral SERD choice?
Sometimes it's a choice and sometimes it's not really a choice, right? So if a patient has an ESR1 mutation, they do have a choice between an injection versus oral therapy. But if they don't have an ESR1 mutation, then their only choice is the injectable fulvestrant. So in a patient where there is a choice, often an oral medication is much more preferred over something that's an injection, especially intramuscular injection into their buttock muscle. But in some instances, there are patients that works better for them. Maybe they have specific issues like cognitive impairment, or so for some reason they can't take a medication on their own. And in those patients, the IM would be often more preferred. So, patients are naturally very hesitant about potential side effects when they're starting new therapy. Um, so often, what I find helpful is to ask them what they've heard about the treatment. and they've Googled it. They've like looked it up. They've talked to friends, and they have these sort of pre-existing notions about what their side effects are going to be. So, I mean, that happens with all of our medications. So I like to like figure out what it is that they think they're going to experience and then really make sure I address those concerns with them. Sometimes they're on point and sometimes they can be totally, symptoms that aren't even known to be caused by the treatment. So, I find that helpful. What do you normally ask your patients when starting new therapy?
I definitely agree with you. One additional question I like to ask is, what's one thing you want to keep doing during your treatment? And for one patient, it was attending a dance class every Tuesday. And so knowing what the patient's priorities can help us make these small adjustments where patients feel seen and respected. And this is where oral SERDs really stand out. In general, we see that they're well tolerated, tend to cause fewer side effects than what patients experience in the first line with their aromatase inhibitors and CDK4/6 inhibitors. And honestly, many patients tell me they have more energy, less body pain, and feel like themselves again, all while keeping their disease under control. It can really provide a real window of relief for these patients, both physically and emotionally.
Beyond symptoms, we need to listen to stories. When we understand what matters most to patients, we can tailor care in the way that truly resonates with them.
I definitely agree. And communication isn't just clinical, it's relational. And when we get that right, we can really empower patients to thrive and advocate for themselves. Well, with that, Sarah and I thank you for participating in this activity. And please make sure to continue to the questions that follow and complete the evaluation.